It is truly an honor for me to speak at this conference. And I have to confess that I didn't actually select the title, but the title is quite appropriate. Is there still a place for direct laryngoscopy? And I'm not going to bury the lead. I'm going to tell you, maybe. But three things I want to talk about today. I want to talk about some of the findings around direct laryngoscopy and video laryngoscopy in children. I want to give you an update on some changes to the ASA difficult airway algorithm. And then finally, I want to talk about this structure that you see in the corner of your image. Some of you may be able to recognize what this is, but I wonder if all of you know what that is. First, let's talk about some airway studies. But before I do that, I have to tell you about Hans, the clever horse. In the late 1800s in Germany, there was a math teacher by the name of Wilhelm von Osten. And he had this idea that animals were smarter than we were giving them credit for, and he was going to prove it. So he took a cat, a horse, and a bear, and he was going to teach them how to do math. The cat wasn't interested. The bear tried to kill him, and so he was left with this horse named Hans. And in fact, he was able to teach Hans how to do simple mathematics. If you asked Hans, what is the square root of 16? He would tap his hoof and stop at the right answer. And he would go around the country demonstrating his math prowess. And actually, clever Hans was like 90% accurate. He was almost as good as a 14-year-old in doing simple math problems. And the New York Times got wind of this. They wrote a whole article about him. And the German Board of Education commissioned this Hans Commission in 1904 to investigate this horse because they said, this can't be real. There's a scam. We're going to figure it out. So they had psychologists, they had researchers of very kind, doctors, watching this horse to figure out what the trick was. And in 1904, they concluded that this horse was really smart and there was no trick. Until Oscar Funks, who was a psychologist, said, you know what, there's your trick, and I'm going to figure it out. And so he separated Wilhelm von Osten from Hans, and then did all the math questions, etc. And Hans would get it right every time. But then he noticed that if the person asking the question, because he would have Hans in front of large audiences, if the person asking the question didn't know the answer to the question, Hans would get it wrong every time. Now, does that give you a clue? And so what Hans would do is, Hans would look into the audience and notice the nonverbal cues of the audience and would stop tapping when he noticed all the members of the audience simultaneously having a slight change in their body language. So all Hans did was tap and look for a consistent cue, all the information from everybody gathered there. That's it. Hans didn't know how to do mathematics, just gathered all the information. So I tell you the story of Hans because I had this epiphany in thinking about whether direct laryngoscopy is still relevant. In critical situations, let's imagine a situation where you're called in stat to come help rescue a patient who's an extremis. And the person in red is in the hot seat. That's the person who's going to intubate. You know, somebody else is coming in and thinking, what's going on? Somebody else is thinking, do we need to do chest compressions? And somebody's thinking about their lunch. There's always one of those. And let's say this person in the hot seat performs a direct laryngoscopy, intubates the trachea and says, yep, so I go through the cords. But then there is no CO2. What happens to the others in the room? They didn't see it, but this person claims they saw it, but there's no carbon dioxide. They all start to question, is that tube in the right place? And someone else will go and make an attempt to confirm that the tube is in place. And this can take away time if the tube in fact was in place and the team needed to move on to something else. Now, if you were using a video laryngoscope, and I just picked one, and this person performed the tracheal intubation in this emergency situation, everybody has the same exact paradigm. Everybody watch the tube go through the cords. We're moving on to the next thing. So this is a situation I didn't really think about that often, but it's something we need to consider when we think about whether direct laryngoscopy should remain our standard. And then there's the argument that you lose your direct laryngoscopy skills if we teach video laryngoscopy. And actually, my experience has been that I can teach you video laryngoscopy better. I can teach you direct laryngoscopy better with a video laryngoscope. Because there are external things I can see you're doing wrong. Obviously, if your eyeballs are right in the laryngoscope, I know you're inexperienced and I can guide you. I can tell by the surface landmarks what's happening inside. But nothing beats seeing the laryngoscope being placed inappropriately in the wrong spot. You can guide the trainee better. You can tell them whether they're doing it right. Like this situation.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
We could guide training better. And so in 2016, the members of the PD Collaborative engaged in a study looking at outcomes in children with difficult airways. The PD Collaborative is a collaborative group of currently about 45 centers collecting data about outcomes in infants and children with difficult airways who are under anesthesia. And so we conducted this study in 2016. And what did we discover? We discovered that when you look at the literature, the published literature on cardiac arrest under anesthesia, this paper from the POCA registry showed that you can expect about 1 in 10,000 children coming for routine anesthetics will have a cardiac arrest. In our difficult airway population, we discovered that 1 in 80 suffered a cardiac arrest. Now, if you do about 500 cases a year, this means that you would expect in routine anesthetics a cardiac arrest once every 20 years. But if all your patients were difficult airways, you would expect 7 every single year. That's what we discovered. 1 in 10 of our patients had hypoxemia. 1 in 35 had laryngospasm. 2% of the time, we failed to intubate. And our overall first attempt success rate was 36%, with the understanding that in pediatrics, we get a lot of repeat patients, and we know what worked last time. 36%. And the interesting thing we found, and this comes back to direct laryngoscopy, was that many times in these patients who tended to have all these complications, the issue was we used direct laryngoscopy way too often, multiple attempts. So the first person goes, the second person does the same thing, and then the third person, oh, well, let me give it to me. I'm an expert. So just like with kids, this repetitive direct laryngoscopy before using an indirect technique was a common finding. We then followed it up with a prospective randomized trial where we compared direct laryngoscopy to video laryngoscopy, led by Pete Vatsis and Anne Garcia Marcinkiewicz. We looked at five centers, 4 in the United States, 1 in Australia, 552 infants, randomly assigned them to direct laryngoscopy versus video, and we found a 5% improvement in the first attempt success rate of intubation and more complications in the direct laryngoscopy group, especially esophageal intubations. You needed more cricoid pressure, and you had more moderate hypoxemia. Now, when you look at this forest plot, To the right favors video laryngoscopy. To the left favors direct laryngoscopy. We broke it down by the clinician type. But if you look at children less than 6.5 kilos, you had a 10% improvement in first attempt success. More than 10% actually improvement in first attempt success. So if we think about the infant surgical problem, about 1.5 million children in the United States, let's assume across the globe 500,000 children need tracheal intubation. And we improve our first attempt success rate from 88% to 98%. That prevents about 20,000 esophageal intubations. Those are 20,000 intubations where there's a risk of cardiac arrest because you put it in the esophagus, or aspiration, or permanent neurologic injury. And so if you combine a laryngoscope with a camera, I believe you've created a high yield technique. So is there a place for standard direct laryngoscopy? So we talked about a few studies. I want to talk about this structure. Does anybody recognize what this structure is? You recognize it now. This structure to me encapsulates our vulnerability. It encapsulates our insignificance. It encapsulates how frail we are. Do you recognize it yet? How about now? Yes. You know, in life we worry about the big things. We worry about catastrophes and weather phenomenon and my family gonna be okay. We don't worry about a single receptor. That's how vulnerable we are. We think we're in control, but we have no idea. And so this resonates with me because I just recovered from COVID a week ago, a pretty significant experience for me. This captures our vulnerability. And, you know, it brought around a lot of change when the pandemic started. There were all these memes that were going around. COVID-19 doesn't affect young people. And I was thinking, great. And then I realized, oh my gosh, I'm not so young anymore. And I'm actually inching into that high risk group. And there were other memes that were being circulated. The neighbor tells me you're chasing people on a bicycle, and he's lying, I don't even have a bicycle. So it brought about a lot of change. And so our PD collaborative group, we're doing all this work, and all of a sudden we found ourselves in lockdown, covering the OR intermittently. And so we had a lot of time. And so we got a number of us together to come up with some guidelines, because there were no guidelines. There was no data when this first started. And so we had these consensus guidelines. We got all these people on a Zoom call, and every single person here contributed to this manuscript, which was a tremendous effort. And we came up with guidelines with the best knowledge we had at the time about the pandemic. And in the news at the time, there was a lot of data about kids not getting as sick from COVID. But we knew that adults had significant issues when anesthetized with COVID. This is a study of 235 hospitals in 24 countries, 1,128 patients, and 51% of these surgical patients had pulmonary complications. 38% had 30-day mortality. And if you were more than 70, more than doubled your mortality, as well as having an ASA status of 3 to 5. But there were still questions about children. So if we anesthetize children, we were wearing all this PPE. Could the fact that we're wearing all this PPE that we're not comfortable with affect the care we give and impact the outcomes of these children? We were intubating and extubating in boxes and drapes. Did that affect the outcomes? And then maybe these kids are fine, their lungs are fine when they're not under anesthesia, but maybe when we anesthetize them, they have more airway reactivity and issues. And so these are the questions we had. And so we put together a subset of the PD collaborative and designed this study we call the Pause COVID-19 study, which was designed to look at specific outcomes across our centers. There were 78 centers in 16 countries, international, and each center collected data for 2 weeks. So you collected every anesthetic you were doing at the time, which naturally involved a lot of urgent cases. And Mel Brooks at Colorado Children's was part of the team that led this effort. Here is a team of folks who assisted with this and contributed to this work, and obviously Ginger Fiadjoe was instrumental as well. So the primary outcome we were looking at was the incidence of hypoxemia in the COVID versus the non-COVID patients. And we defined it as mild, moderate, and severe. And our secondary outcomes were looking at the first attempt success rate of intubation, complications during the anesthetic, particularly during induction and emergence. And we wanted to know if you had symptoms of COVID, did that increase your risk of complications? We collected almost 15,000 cases. That was a record for me. And it just shows the power of collaboration. We collected 15,000 cases. But the issue was we had to get rid of about half of those cases. Why is that? Because we designed this in a novel way. The lockdown had just happened. We couldn't really go through an IRB process. And so we decided to set this up with a de-identified registry. So not collecting any PHI, and the IRB gave us an exemption for that. And so we created this online data entry portal, and clinicians entered the data. But because we didn't have any PHI, there was no way for us to vet the completion of the data or go back and collect additional information. So we had to get rid of almost half, which is a significant limitation because of incomplete data. We analyzed about 8,000 cases, of which 7,500 or so were COVID negative and 300 plus were COVID positive. A small number relatively, but a large number of COVID cases at the time. So what did we find? We found that if you had COVID, you almost had 3 times the incidence of hypoxemia. You had greater than 3 times the incidence of moderate hypoxemia, and you were more than twice as likely to have a complication. Many of the complications we saw occurred at emergence and removal of the airway device. And if you had symptoms, you had an odds ratio of 2.7 for having complications. And any complication, double the rate. And we looked at barriers. So I told you we're intubating in these boxes, et cetera. What was the impact of barriers? And really what they did was they improved the first attempt success rate, surprisingly. So actually, I don't know if people were more careful or the more experienced people were doing these intubations, but hypoxemia, mild hypoxemia increased when you use the barrier. So some impact of using a barrier. How about video laryngoscopy use? The William von Osten, clever Hans, important to get all the information. If I'm taking care of a patient with COVID, that is the kind of patient where I want a video laryngoscope, because I can be further away from the airway and I can have input from everybody in the room. Everybody shares the same paradigm. We use them 29% of the time in these COVID patients. Surprisingly, not sure if that was a lack of equipment issue or just reluctance to use it. 60% of the time we did an inhaled induction, demonstrating the comfort level of pediatric anesthesiologists with inhalational induction. People may not have been as concerned about the aerosol generation, which we had actually talked about in our previous publication. But there are limitations to studies like this. And one of them I'd like to talk about is related to World War II, when the French planes were taking a beating. The planes were coming back to the base with lots of holes in the wings, and the French wanted to protect their planes, and they said, you know what? And they were losing planes, and so they said, you know what? Let's armor plate the wings, which adds weight and burns more fuel and costs more. And an astute statistician, Abraham Wald, said, you know what? You need to plate the areas that don't have holes, because those planes never made it back. They had a selection bias. They were selecting for planes that actually returned. They should have been thinking more holistically. There's a selection bias in our COVID data. People tend to remember eventful cases more than others. And given our limitations with the way we collected the data, that's something important to note. But finally, we had some data, unlike this tennis interview after a tennis match at the US Open.
Congratulations.
Congratulations. I lost.
You lost?
Yes.
Oh, okay. So what happened out there?
Are you serious?
No.
Did you watch the match?
So we've talked about some studies around video laryngoscopy. We've talked about this structure, and now I want to give you an update about the ASA difficult airway algorithm. This is the new pediatric difficult airway algorithm. And we started this work in 2019 BC, 2019 before COVID. A number of us had started doing this work, and then COVID happened, so we pivoted to remote. And around 2021, we were continuously working on this. I moved from Children's Hospital Philadelphia to Boston Children's Hospital. And that was a big life event. It was a big life event for my family. Here's my wife and my two daughters. The one on the left is my younger daughter, Leah. And she particularly was very unhappy about moving. She had a circle of friends. I'm not moving. When we were getting ready, my wife and I were packing boxes down to the basement for the movers to pack the boxes. We were hearing these loud thuds, and I go back in the house, and there's Leah upstairs dropping boxes from upstairs downstairs. And I look at her, I'm like, what are you doing? She's like, work smarter, not harder, Daddy. And so she was reluctant to move. Anyway, we move, and they're adjusting to this new place. I come back from work on the first day of school, and they are all crying, big tears. But I didn't panic. I just acknowledged their tears. They were big tears like this child.
We got to go to Drew, the farm kid. How you doing there, Pally? Right now, I know he can't say anything right now, but you know what he's saying right now? E equals MC squared. Get the camera off my face. I'll take this cantaloupe.
Oh no. So I came home.
Dan, don't make him
politician.
cry.
Oh no. So I came home. These smiles were not smiles. They were all tears. But I just acknowledged, it's like, you guys seem unhappy. And I kept going because I knew about the Bob Glazer 4 stages of change. Bob Glazer is the CEO of a company called Acceleration Partners. And he talks about change and how hard change is, moving, etc. And he says there are 4 stages. The first stage is you're confused and surprised. Why'd you change? Why do we have to move? And then you go to reacting to the difference. I'm not sure I like this. And then you start wanting to go back to the past. I want to go back, Daddy. This is not great. And eventually you adapt and accept. And say, actually, this is much better. And so my daughters were in one of those stages. But 3 months later, when I asked them, what do you guys think about your school? They're like, we actually love our school. It's actually better than our previous school. We have friends now. So there's always change. And I tell you that because this new algorithm is so different from the one on the left that you have used to. And so some of you are freaking out and saying, this is terrible. What did you guys do? Why is there all this color? Why are these? Let me go through it. This is the team that helped to create this new algorithm. And we thought a little bit differently and out of the box about this. And Ginger Fiadjoe, of course. First of all, it's international. These are all the countries that are represented. And like any good wedding reception, the traditional algorithm was always only for adults. And so during our first meeting, I spoke up and I said, listen, I know this algorithm is designed for generalists, but many children are cared for by generalists. And the team bought into it. And that's why we have a pediatric version. We looked through thousands of abstracts, came up with 560 references. Where we didn't have data, we looked to expert opinion. And first thing you notice is their images. Why are there images? They're images because pictures are not only more effortless to recognize and process than words, but also easier to recall. And you're thinking, why is he reading me text and telling me this? When words enter long-term memory, they do so with a single code. When pictures, on the other hand, enter memory, they contain 2 codes, one visual and the other verbal, each stored in a different place in the brain. But I could have not shown you that text and just showed you a picture. So text uses the verbal, and images use visual and verbal and are stored in different places. You see how that might come off a little better and be easier to remember. Actually, they've tested this. It's called the picture superiority effect. If you say circle, 10% of people remember that 72 hours later. But if you draw a circle, 65% remember that 72 hours later. Twitter knows this. Tweets with images are retweeted 150% more. That's why they included that. And then we say deliver oxygen throughout. And it's throughout the algorithm. Why do we do that? We all give oxygen before when we mask induce, and then we go to do direct laryngoscopy, which is really the highest risk time right? When you're putting the tube in, and we don't give any oxygen at that time. Why not? I think of it like, a parachute. You're going to parachute out of a plane. You put your parachute on in the plane as you're flying up, but then right when you're about to jump, the highest risk time, when you're doing the intubation, you render the mapping. You take your parachute off and then jump without it. No, keep your parachute on. So let's give oxygen during the intubation. You can use high flow systems, modified nasal trumpets, important thing in the algorithm. Then you notice there's color, right? The color means something. And so, color gives you contrast and detail. You can see the difference between these two pictures. But the red indicates situations where ventilation is impossible. The yellow indicates situations where it's marginal. And the green is when ventilation is easy. And I have there on the left, when you're in this difficult area algorithm, this should be a no direct laryngoscopy zone. And then we want you to do a timeout. We want to get into a routine of doing a timeout before a difficult airway. Difficult airways are not that common. We really should be prepared and get into routines. And routines are really important. I'm a big tennis fan, and Rafael Nadal has this routine that he does before he serves every time. And this is it. He does a wipe of his face in the same way. But guess what? He's been doing this since he was that old.
Nadal is known for his use of routines. And as you can see from this video,
So let's get a routine. And the routine is, and this is what I try to do. First, you do a timeout. First, we make sure we have the right equipment and our backup equipment. And then we want you to assign roles. So assign a primary airway manager and a backup airway manager. So you know who's going to make the first attempt, who's going to make the second attempt, who's going to define that before you start. And then discuss and consider an invasive airway management, or ECMO, if that's going to be a consideration. And then identify who's there to help if you need additional help. You don't want your help to be caught out, not available. You don't want your help to be like Mike.
Ma'am, he's running me over.
No, I'm not.
Ma'am, hurry, please, hurry. Mike!
Mike, you want to make sure your help has been identified and is available. And then we say treat anatomical and functional obstruction. What does that mean? Anatomical obstruction, we treat with devices, oral airways, etc. Functional obstruction, you need drugs. And so that's paralysis. If you're in a situation where you can't ventilate, you're heading towards a surgical airway, you should absolutely paralyze the patient. Some people have a problem with that. And we have a problem with that, I think, for two reasons. We have a negativity bias. We're worried about all the negative consequences of paralyzing and not being able to ventilate, but you can't ventilate already. So we still have to overcome that negativity bias. We have all this good, but we focus on the one bad thing. And then there's a loss aversion. So the pain from a loss is greater than the pleasure from a gain. And those two things come into play when we're managing airways. And I had my recent example of negativity bias / loss aversion when I had COVID. So I had a temperature, and I thought to myself, you know what? I'm fine. I've got all the vaccines. It should be good. It's going to be mild, just the sniffles. And I knew there was a drug out there called Paxlovid that apparently helped with COVID. And I was like, okay, I'm fine. And then I had this headache. My head was going to explode. And then I started coughing. This is actual audio of my cough. The only thing I can tell you is analogy I can make is like it felt like I was drowning. And after one night of that, I was like, give me the Paxlovid. And I took it and it transformed my course. A week ago, I could not speak. And you would be shocked about how transformative that drug was. But I had this loss aversion about this drug. I had this negativity bias. And so give the muscle relaxant if you are in that situation. Then it's important to debrief, I believe, at the end. The end of the movie matters. How you end everything matters. There's a lot of negative things that can happen when you manage children with difficult airways. And Daniel Kahneman did an interesting study where he took patients getting GI endoscopy and randomly assigned them to an hour-long endoscopy or a 15-minute endoscopy. The hour-long group had a lot of pain, a lot of discomfort, and in the end, they just left the scope in there for another couple minutes doing nothing. And then the 15-minute endoscopy had a very little pain, but then in the end, they did a lot of stimulation, so increased pain at the end. The group that had the most pain was more likely to sign up for another endoscopy because the way it ended mattered. And people remember, we disproportionately remember how it ends. So you have a difficult airway, have a debrief, put things in context, understand how you could do better, listen to the team. Critical. So we added that to the algorithm. And I'm going to conclude with this. So it was this email that went around in our at CHOP to several DL groups. And it was from the parking office announcing that there were premium parking spots available in one of the garages. And there was a rate for that. And if you were interested, let us know. But it went to all these DL groups. And so somebody responded, when they say premium, does this mean in addition to the free parking we already receive on nights and weekends? Or does this mean we now pay for parking in general? Replied all. Somebody followed up with, is that a good deal? And then they responded, no, this is not. This is going to hundreds and hundreds of people. Then somebody says, stop using reply all. Replies all to say that. And then somebody says, I would appreciate that too. Yes, please. They're all asking people to stop replying all, but they're replying all. And it keeps going on and on. Reminds me of COVID going on and on. Someone says, I'll trade 1 year of parking at the university garage with a scenic view of the newly built parking garage and the guy with the dog on the corner. This was getting nuts. And eventually, somebody says, stop replying all. Thank you for the emails. Please respond directly to parking and transportation. I really will appreciate it, replying to everybody. And someone eventually draws a circle around reply all and sends it to everybody. And it goes on and on. Eventually, the residents send this picture. Please don't reply all to this email chain. It makes a sad doctor. Like, this thing took a life on its own. It went on for days. And after this person posts this image, somebody replies, sorry, the image is not loading correctly. Can you please resend? Thanks. And then it just stopped. Nobody replied, and it was over. And I'm hoping that one day, COVID's just going to stop. The COVID gods are going to not reply, and it's going to be over. Anyway, we talked a little bit about airway management, we talked about the algorithm, and we talked about the spike protein. Is there still a place for direct laryngoscopy? I'm going to share this video with you of the Formula One pit crew. They just did this tire change in 2 seconds. In 1940, which is when we first got direct laryngoscopes, it took a minute. And now we're at 2 seconds. Are we going to continue to use our 1940s technology in 2022? And my bias is this. This is what we should do with our standard direct laryngoscopes. And I'm sure somebody's going to disagree with me, and that's going to be great. But remember, most conflicts can be resolved over drinks, so we can discuss it over drinks. Thank you all for the invitation.